Bismillahirrahmanirrahim. Today we will be discussing the topic of pulmonary edema. So you have to recapitulate your knowledge about the edema from your third year topic, hemodynamics. So edema is the accumulation of excessive fluid within the interstitial space. So it is the accumulation of fluid both intracellularly and extracellularly. However, the presence of fluid should be outside the vascular space. So this is the generalized definition of edema. Now what is pulmonary edema? Pulmonary edema is the leakage of excessive interstitial fluid which accumulates in alveolar spaces, thereby compromising the lung function, the lung compliance and the capacity of the lung to exchange air. So now coming to the classification and causes of pulmonary edema. The pulmonary edema is divided into two main types: the hemodynamic edema and the non-hemodynamic edema. The hemodynamic edema is also referred to as the cardiogenic pulmonary edema, while the non-hemodynamic edema, the non-cardiogenic pulmonary edema, is the edema that occurs due to alveolar wall injury. So what is the hemodynamic edema? It is due to increased hydrostatic pressure and decreased colloid oncotic pressure. So before knowing about the causes of this hemodynamic edema, you should first be able to know the causes of increased hydrostatic pressure. So the hydrostatic pressure is the pressure that is exerted by the fluid in the closed compartment. So it is the pressure exerted by the blood within the intravascular space. So it is normally equal to the oncotic pressure that is exerted by the plasma protein within the vessel wall. So under normal circumstances, there is no leakage of fluid between the intravascular and the extravascular space. So whenever due to any cause there is increased in hydrostatic pressure and decreased oncotic pressure, the fluid moves out of the capillaries or the vessels into the interstitial fluid, ultimately leading to edema. So the causes of increased hydrostatic pressure are the left-sided heart failure, volume overload and the pulmonary vein obstruction, and the causes of decreased oncotic pressure are the causes that leads to reduced serum concentration of plasma proteins. So these are the hypoalbuminemia, nephrotic syndrome, liver disease and the protein losing enteropathies, and the lymphatic obstruction. So whenever the capacity of lymphatics to drain this excessive interstitial fluid is reached, so there is accumulation of fluid, and this fluid ultimately leaks into the intracellular spaces, leading to pulmonary edema. So the other cause of pulmonary edema, the non-cardiogenic pulmonary edema, can either be due to pulmonary infections, the chemical injury, the physical injury, the radiation-induced damage, and the inhalation of toxins. So the causes could either be infections, the inhaled gases, the liquid aspiration, radiation, then indirect injury, which could be due to septicemia, blood transfusions, burns, then certain drugs and chemicals like certain chemotherapeutic agents and certain medicines leads to indirect injury to the alveolar pneumocytes, then shock and trauma, and then the edema of undermined origin, the high altitude and the neurogenic or the CNS trauma. So now coming to the detail of the cardiogenic pulmonary edema. The cardiogenic pulmonary edema or the hemodynamic pulmonary edema is the edema that occurs as a result of increase in capillary hydrostatic pressure secondary to elevated pulmonary venous pressure. So what is the pathophysiology behind this cardiogenic pulmonary edema? In patients with left-sided heart failure, when the left is unable to pump the blood out of the heart, then this excessive blood ultimately moves back from the left ventricle to the left atria, and from the left atria it is drained into the pulmonary veins. So whenever there is excessive pressure within the pulmonary veins, it can lead to pulmonary hypertension. So this back pressure will ultimately result in overburdening of the pulmonary capillaries, leading to their increase in hydrostatic pressure, and ultimately the fluid moves out of the vessels into the interstitial spaces, which are the spaces that are present in between the capillaries and the alveoli. So whenever the capacity of the lymphatics to drain the interstitial fluid is exceeded, the interstitial edema develops, and ultimately there is loss of lung compliance. So with further increases in this interstitial pressure, the tight junctions between the alveolar epithelial cells open. So this extravascular edema that is present in the extracellular spaces will ultimately move to the intracellular spaces, that is the alveolar spaces, causing alveolar edema. So the ventilation stops at this stage, and with chronic edema, there is increased susceptibility to infections because alveolar edema fluid is a good culture media, so it can lead to secondary pneumonia. So this is again the more detailed description of the pathophysiology. So normally the hydrostatic pressure and the colloid osmotic pressure are kept in balance in order to prevent the outflow of fluid. So the resorption of fluid is determined by the difference in the oncotic pressure between the two compartments. So there may be hydrostatic, oncotic, or the permeability difference that can lead to the severe form of edema. So there are two types of edema: the interstitial pulmonary edema, which is the earliest phase and it is an exaggeration of the normal process of filtration, and then the alveolar pulmonary edema, when the fluid can no longer be contained in the interstitial space due to the capacity of the lymphatics to drain it. Then it spills into the alveoli, a condition that is termed as alveolar edema. So there is increased in capillary hydrostatic pressure due to left-sided heart failure. So a rare form of edema follows rapid aspiration of large pleural effusions and occurs on the side of aspiration re-expansion pulmonary edema. So it has been suggested that interstitial pressure rapidly becomes more negative, drawing fluid into the interstitial space and then into the alveoli. So what are the pathological features of hemodynamic or the cardiogenic pulmonary edema? The lungs become wet, heavy, boggy as a result of accumulation of fluid, especially in the dependent basal regions of the lower lobes. So what are the microscopic features? There are engorged pulmonary capillaries and filling of intra-alveolar spaces by pink granular exudate. So in chronic congestion and edema, there may be interstitial fibrosis associated with microhemorrhages and numerous hemosiderin-laden macrophages that are referred to as the heart failure cell, as I have already mentioned in my lecture of left-sided heart failure. So with time in the fibrosis stage or the resolution stage, there is thickening and fibrosis of the alveolar walls that can cause the lungs to become firm and brown, a condition that is referred to as the brown induration of the lungs. So this is the histomorphological features of the lungs in case of cardiogenic pulmonary edema. As you can see, there are dilated capillaries within the alveolar walls. There is accumulation of fluid within the alveolar lumen, that is the transudate, and there is thickening of the alveolar walls and interstitial edema. This is again a more magnified power. The transudate in the alveolar lumen, the dilated capillaries, and the thickened alveolar walls as a result of acute pulmonary edema. Now coming to the other cause of pulmonary edema, that is referred to as the non-cardiogenic pulmonary edema, or the edema that is caused by the microvascular injury. It occurs as a result of excessive increase in the permeability of the endothelial cells of the capillaries and damage to the alveolar epithelial cells as a result of numerous conditions, as I have already mentioned. So ultimately there is accumulation of inflammatory exudate within the interstitium and finally within the alveolar spaces and the alveoli. So this may lead to compromised respiratory function, that is referred to as the acute respiratory distress syndrome, the acute lung injury, and histologically the changes that occur in the lungs in the case of acute respiratory distress syndrome are referred to as the diffuse alveolar damage. So what we will be discussing under this topic is the outline, the definition, the clinical history, the pathophysiology, and finally the diagnosis and the management. So the patient presents clinically. This is a scenario that a 35-year-old male patient met with a road traffic accident and he is admitted in surgery ICU, and he has developed severe tachypnea, that is increase in respiratory rate, dyspnea, shortness of breath within 24 hours of admission. And on examination, he has tachypnea, his respiratory rate is higher, tachycardia 110 beats per minute. The blood pressure is 80 by 50. He has hypotension. He has developed hypotension. There is pallor, cyanosis, and there is no increase in JVP. So there are unaudible heart sounds, and the chest shows bilateral rales present in the mid-lower area. And on per abdominal examination, it is soft. There is no hepatosplenomegaly. So we have done the arterial blood gas analysis of this patient, and it shows a reduced oxygen saturation, that is 50%, partial pressure of oxygen 40%, and the partial pressure of carbon dioxide 45%, and pH is in within normal range at the borderline 7.3. So what should be the diagnosis? The patient is developing respiratory insufficiency or the acute respiratory distress syndrome secondary to trauma that has ultimately lead to activation of coagulation cascade or the sepsis. So the chest x-ray of this patient shows the pulmonary infiltrates most commonly within the lower lobes of the lung, and the patchy pulmonary infiltrates, which supports our diagnosis of non-cardiogenic pulmonary edema. So what is the definition of ARDS? The ARDS is a clinical syndrome of dyspnea of rapid onset, hypoxemia, and diffuse pulmonary infiltrates leading to respiratory failures. So the inflammatory cells and the proteinaceous fluid accumulate within the alveolar spaces, leading to decrease in diffusion capacity and hypoxemia, that is reduced in oxygen saturation. So what is the difference between the acute lung injury versus ARDS? Before understanding this concept, we should know what is meant by the partial pressure of oxygen in the artery. So this is the PaO2 refers to the partial pressure of oxygen within the arteries. So it is normally 75 to 100 millimeter of mercury, and FiO2 is the fraction of oxygen within the inspired air, and at room temperature the concentration of oxygen within the inspired air is 21%. So the FiO2 in the normal person should be less than 0.2. So ALI is the term that is used for patients with significant hypoxemia, that is their PaO2 and FiO2 ratio should be less than or equal to 300. However, acute respiratory distress syndrome is the severe form of ALI in which there is severe hypoxemia. However, this definition is again revised by the WHO. So the normal partial pressure of oxygen versus FiO2 ratio is greater than 400. So whenever this ratio is reduced, so the patient is categorized as mild, moderate, and severe ARDS. So in the case of severe ARDS, this ratio should be less than 100, while in the case of moderate ARDS, this ratio should be between 100 to 200, while in the case of mild ARDS, it should be between 200 to 300. So it is the ratio of the partial pressure arterial oxygen and the fraction of inspired oxygen, and is also referred to as the Carrico index. And it is the comparison between the oxygen level in the blood and the oxygen concentration that is breathed from the outside. So what should be the difference? As I've mentioned in the previous slide, both these conditions are acute, and ARDS is more severe as compared to acute lung injury. And in ARDS on chest x-ray, there are bilateral, interstitial, and alveolar infiltrates. And the pulmonary capillary wedge pressure should be less than 18 millimeter of mercury. So the ARDS diagnostic criteria is that it is the acute onset secondary to a predisposing condition with bilateral patchy lung infiltrates with the ratio of arterial oxygen saturation and fraction of oxygen in the inspired of less than 200 millimeter of mercury, and the pulmonary capillary wedge pressure of less than 18 millimeter of mercury. So the ARDS causes, as I've already mentioned, in the causes of non-cardiogenic pulmonary edema could be due to direct lung injury, due to pulmonary infections, contusion near drowning, then inhalation injury and aspiration of gastric content, and indirect lung injury like in the case of acute pancreatitis, transfusion of blood products, severe trauma in the cases of sepsis and hypoperfusion. So this is the diagram of your Robbins showing that both the infections, the physical, the chemical injury, the hematological conditions, inhaled irritants, and certain generalized conditions may predispose the patient to the development of ARDS. Among these causes, the most common causes that leads to 50% of the cases of acute respiratory distress syndrome are pancreatitis, uremia, cardiopulmonary bypass, and hypersensitivity reactions. So among the infections, there are diffuse pulmonary infections, and among the physical injury, as I've already mentioned, the radiation, fractures with fat, embolism, mechanical trauma, and among the chemical injury, heroin or methadone overdose, acetylsalicylic acid, and barbiturate overdose. And among the hematological condition, the DIC is the most common cause that may lead the patient the development of ARDS. So among the pathophysiology, there is diffuse alveolar damage, the lung capillaries damage, inflammatory cells, alveolar edema, severe hypoxemia, decreased lung compliance and atelectasis, and pulmonary hypertension. So the natural history of ARDS, there are three phases: the exudative phase, which remains for approximately 0 to 7 days, and then the proliferative phase, which remains for 7 to 21 days, and the last stage, which is the fibrotic stage. After 21 days, this stage begins. So the sequence of events that occurs in ARDS that I will explain you with the help of a diagram is that first of all, there is activation of the endothelial cells of the pulmonary capillaries, as a result of which there is recruitment of the inflammatory cells that are the normal constituents of the blood, including the neutrophils and the monocytes, which migrate from the capillaries into the alveoli, and ultimately they adhere to the wall of the alveolus, leading to formation of haline membranes. And after the formation of haline membranes, if the inflammatory event stops, then the resolution of injury or the fibrosis occurs. So this is the natural sequence of events. On the left side, this is the structure of the normal alveolus. As you can very well appreciate, the type 1 alveolar epithelial cells, and then the type 2 cells, and then the interstitial space, and the pulmonary capillaries. So within the pulmonary capillaries, there are neutrophils, blood platelets. So under the influence of any infection or a stimulus, there is activation of endothelial cells, and ultimately a gap develops in between the endothelial cells, and these neutrophils are recruited into the interstitial space, and ultimately they enter the alveoli. So after entering the alveoli, they degranulate and release the reactive oxygen species, proteases, and leukotrienes that may damage the alveolar epithelial cells. Both the type 1 and the type 2 epithelial cells undergo damage. So with time, as a result of more accumulation of edema fluid within the alveolar spaces, there is formation of pink exudate and haline membranes that develop within the wall of the alveoli in replacement of these alveolar pneumocytes. So these alveolar macrophages that are the normal resident of the alveoli, they are the main stimulus that release factors like tumor necrosis factor and interleukin 8 that may lead to the endothelial activation. So whenever the inflammatory stimulus is removed, then these are the alveolar macrophages that leads to the engulfment of the cellular debris and the neutrophils, ultimately leading to the removal of these neutrophils from the site of infection, and they may synthesize collagen and the proliferation of fibroblasts, ultimately leading to the fibrosis and thickening of the alveolar spaces. Moreover, they also release certain factors like platelet-derived growth factor and the transforming growth factors that may stimulate the collagen deposition and ultimately the thickening of the alveolar walls. and also there is proliferation of the bronchial stem cells that may lead to replacement of the pneumocytes. So this was the pathophysiology of the acute respiratory distress syndrome, and all of these changes histologically are referred to as the diffuse alveolar damage. So this is again the fibrosis stage of acute respiratory distress syndrome. As you can very well appreciate, the alveolar macrophages undergo phagocytosis and apoptosis of the neutrophils and the proteins and the cellular debris, and these may lead to deposition of type 1, type 3 collagen and the fibroblast and fibronectin, leading to the fibrosis of the alveoli. So these are the histological findings: the DAD or the diffuse alveolar damage, the hyaline protein in air spaces, and the cellular congestion. So there is alveolar inflammation, the thickened septa from protein leak, there is congestion of the pulmonary capillaries and decreased alveolar volume. So what is the clinical history of acute respiratory distress syndrome? The patient presents in acute stage critically ill with dyspnea, trachypnea, hypoxia, and initially there is respiratory alkalosis and ultimately the respiratory failure. So what are the lab investigations? There should be routine blood counts, renal function test, chest x-ray, arterial blood gases, CT chest, brain natriuretic peptide, echo, bronchoalveolar lavage, and the estimation of pulmonary capillary wedge pressure. So normally the concentration of oxygen, the arterial blood gases are normal. 75 to 100 millimeter of mercury should be the normal partial pressure of oxygen, and 35 to 45 millimeter of mercury should be the normal partial pressure of carbon dioxide, and the normal blood pH should be 7.35 to 7.45. So any imbalance in these conditions may refer that it is the case of ARDS. So how to determine ARDS by chest x-ray? It can be difficult to do. Should always try to make the diagnosis in the light of clinical picture. You should determine whether it is cardiogenic or non-cardiogenic edema. So the cardiogenic pulmonary edema, there is more infiltration in the basal areas of the lung and the prominence of curly B lines due to dilated and engorged pulmonary capillaries, and there should be cardiomegaly. However, in the case of non-cardiogenic pulmonary edema, there should be no cardiomegaly and there are bilateral patchy infiltrates. So this is the difference between the cardiogenic and the non-cardiogenic pulmonary edema. There should be absence of curly B lines, cardiomegaly, and there should be homogeneous puffy shadows in the case of non-cardiogenic pulmonary edema. And the exudate, there should be exudate, that is the accumulation of protein and inflammatory cells within the edema fluid. So this is again the CT chest showing septal thickening that is more severe in lung bases in the case of cardiogenic pulmonary edema. Now what should be the management or the therapy goals? We should treat the underlying cause of the patient. There should be cardiopulmonary support, and specific therapy should be targeted at lung injury, and then there are other modalities, the supportive therapy. So in spontaneously breathing patient, in the early stages the hypoxia may be corrected by 40 to 60% of inspired oxygen, and if the patient is well oxygenated on 60% inspired oxygen and empirically stable, then ward monitoring is feasible, but close observation and regular estimation of arterial blood gases is required. So what are the indications for mechanical ventilation? If the partial pressure of carbon dioxide, which in the normal cases is 35 to 45, it is greater than 50 millimeter of mercury, and if there is inadequate oxygenation, the FiO2, which should be normally maintained below 0.5, is greater than 0.6, then the patient should be considered as a candidate for mechanical ventilation. So the aims of the mechanical ventilation are to increase the arterial partial pressure of oxygen while minimizing the risk of further lung injury, that is the ventilation induced lung injury. So this is the knowledge of medicine, that what are the ARDS net ventilator protocol that you should discuss in your medicine wards that what should be the tidal volume, the ventilator mode, the FiO2 and the PEEP ratio. PEEP is basically the positive end expiratory pressure, which is the pressure that is exerted within the lungs at the end of normal exhalation, and it is normally pressure that is required to keep the pressure of oxygen within the lung greater than the atmospheric pressure. So this is uh, used in conjunction with the ventilation in order to prevent the ventilator induced lung injury. So the low tidal volume mechanical ventilation should be used because in ARDS there is large amount of poorly compliant lung and a small amount of healthy compliant lung. So if there is large tidal volume ventilation, then it can lead to overinflation of the healthy lung tissue, leading to ventilator induced lung injury. So the tidal volume is the normal volume of air that moves in and out of the lung during normal ventilation. So we use positive end expiratory pressure in these cases, which prevents further lung injury due to shear forces by keeping the airways patent during expiration. So the pressure within the lung should be greater during expiration as compared to the atmospheric pressure. So other methods are the high flow ventilation, the ECMO and the partial fluid ventilation. Now, what is extracorporeal membrane oxygenation or ECMO? It is the machine that is similar to the machine that is used in cardiopulmonary bypass surgery, and it is the mechanism in which we keep the heart and lung at rest so that they can heal properly. In this case, the blood is drawn from the right ventricle of the heart, and it is oxygenated with the help of a machine that is present outside of the body. So there is extracorporeal membrane oxygenator that may leads to oxygenation of the deoxygenated blood, and ultimately the oxygenated blood is returned to the heart. So this is the machine system that is present outside of the body in order to keep the diseased heart and lungs at rest so that they can heal properly. So the patient should be kept on ECMO machine for not more than 9 days. So other management systems are the conservative management. We should reduce ICU stay and the duration of ventilation, and steroids can also be used, which should be gradually tapered. And then for the treatment of sepsis, the empirical antibiotics, and then depending upon the culture and sensitivity results, we can change antibiotics. We should avoid the nephrotoxic drugs because the patient is already septicemic and he's the potential candidate for multi-organ failure, and enteral feeding is recommended. So what is the prognosis? The mortality rate ranges between 26 to 44%. So the risk factors are the advanced age, the chronic kidney disease, the chronic liver disease, then chronic immunosuppression, and the persons who are chronic alcoholic abusers. So the ARDS from direct lung injury has double mortality. So this is the last slide that is showing the distinguishing factors between the congestive heart failure, ARDS and pneumonia. So main differences are the JVP that is raised in the case of congestive heart failure, and the bilateral infiltrates that are in majority of cases are present within ARDS, and the PaO2 and FiO2 ratio of less than 200 that is present within ARDS, and the brain natriuretic peptide and cardiomegaly, it is normally seen in congestive heart failure. So these are the differences that are seen in these three conditions. So these three conditions should be diagnosed in the clinical background, and then afterwards the histology confirms the diagnosis of ARDS and pneumonia. So thank you so much.